All right, so just to let you know, the review for the exam is right after class today. We'll be meeting. So you'll have your exam grades tonight. That's the one thing that's good about testing on a Friday. Is usually we have the exam reviews like right after, testing week, and so um, you'll be able to get your grades. Um, Excuse me. So I will post those as soon as we are done reviewing the exam um this evening. So today we are going to finish up chapter 17. It's a little bit more talking about job roles and responsibilities. So this is going to be pages, I think it's two, just let me double check so I don't tell you something wrong. It's pages 240 through 247 in your textbook. Um, So I will share my screen as soon as I get there. All right. Share. All right. Can everybody see the PowerPoints? Thumbs up if you can see the PowerPoints. I'm like, thank you, Dominic. All right. Um, I am so sorry. I've been sick all week. I'm trying to get over it really bad. Just I'm ready for it to be done. Um, So LPN job description as a charge nurse. Um, so when we look at LPNs in charge positions, and most of the time when we look at this is going to be in a long-term care situation. Usually requires a minimum of 1 year experience to be a charge nurse. Obviously, you'll have to have a current license in your state of practice. I will tell you that it does most of your long-term care facilities. Um, if you are hired. Most of them consider everyone a charge nurse unless your specific role is to just pass medications. It depends on how your organization is set up. Um, and so some of the things that, you'll be required to perform as part of your charge nurse duties would be to collaborate with with the RN, I'm sorry, and other team members so that collaboration with the interdisciplinary team, so dietary activities, social work, physical therapists, your care managers. You'll also assist the DON in new employee orientation, as well as evaluating the work performance of your nursing assistants. So some of the other responsibilities, especially for collaborating with the RN, you'll assess and evaluate your residents' conditions at all times. So you'll have to know your residents pretty well. You'll assign tasks to your nursing assistants. So it's really important that you know their abilities, and their skills. You'll provide care, within your scope of practice, according to the physician's orders, of course, by policy, and establish standards of care. Um, you'll recognize symptoms of pending adverse developments and report those. And that's why I said it's really important that you know your residents, that you get to know your residents, and that you'll be able to pick up on some of those really subtle changes that occur. So you'll report any changes, and then of course, try to assist with what you can do to, respond to any of those changes. Give medications, you will do treatments, what else? Maintain accurate and complete records of nursing data, um, interventions, including documentation in your EMRs, efficiency in completing your workload, including neatness and orderliness. You delegate duties as appropriate to your CNAs or your nursing assistants. You'll establish a safe and hazard-free environment. You'll maintain patient privacy as well as the dignity of residents. Other duties, you'll assess, plan, implement, and evaluate client care per the plan of care. Um, Safe medication administration, of course, we can't. We always have to be careful with that. How do we ensure safe medication administration? So, what are some of the ways that you can ensure that you are providing for safe medication administration?
Right name, right
Right, those.
patient.
Right, following those 9 rights on medications, right? How many checks do we do? All right, good job. Um,
Two.
so yeah, making sure that's one of the biggest things. I don't know. Has anybody ever seen a med cart in long-term care? Does anybody see the inside of a med cart in long-term care? It can be a little hairy, right? Depending on your facility and how it's set up. So I've worked in some facilities where the LPNs or the RNs, whoever is working the cart, they give all the medications. I've also worked in facilities where you have med techs give the medications. And so med techs will give all the PO medications, right? Like the standard what do you call it? The scheduled medications, right? But they don't do IV medications, they don't do injections, and they don't do PRNs. Or peg tube administration, right? So they'll give all the PO medications, and then the charge nurse, will do any IV medications, your insulins, um, and all the G tube medications. And I've also seen some, um, like we had a patient, we had a resident who, I don't know if he didn't, I don't think he thought that he was getting all his medications. So rather than have the med tech give him, we had to have the nurse give them. So it really depends on how your facility is set up. Um, You're also maintaining documentation and charting. So your vital signs, hold on, your vital signs, your medication, your treatment plans. Um, you'll notify provider of changes in and not in an appropriate manner. You'll document your orders received. You'll communicate with the pharmacy. So, you need medications, you may have to call the pharmacy. Um, Assist in maintaining physical, social, and psychological environment for residents that is conducive to their best interests as well as welfare. Excuse making sure that you're doing appropriate shift and handoff report, as well as providing a report to your nursing assistants. Most places, when when you have a full staff or, regular staff, of course, your nursing assistants may be consistent on that unit. But if you have a floater, a new CNA, or even like I said, a floater or a new CNA, you want to make sure that you're giving them a report on those residents as well, so that they have some idea about those residents. You want to make sure that you are assigned tasks that are appropriate to your for your nursing assistants. You'll supervise, assist, and evaluate any delegated duties. Um, you may have to go to care team and department meetings. So like a lot of places have like a 9 o'clock meeting that you may have to go to give, just a overview of what's going on your unit and get any pertinent information from leadership. Care team meetings. So care team meetings are pretty interesting. They have the social worker. They'll have the like the what we call the MDS coordinator. They'll have like, the therapy will be in there, activities will be in there, sometimes dietary will be in there, and then as well as the resident and the family. And they'll go over what the plan of care is for the residents, any medications, like how they're doing in therapy. Um, if they're not in therapy, any other changes in their condition or anything that they may need. And so as a nurse, you're there to provide that information. Additionally, just to answer any questions that either the resident or the family have regarding any of the treatment plans. Um, you want to follow your regulatory codes and guidelines for both federal and state. And then you'll also participate in orientation of employees, whether it's a CNA, even another nurse. Um, Regulatory codes and guidelines, both federal and state. So they have what's called the Big Red Book for long-term care. It's a book, it's really thick, and it lists all of the codes and anything that you could potentially get a violation for when state comes in to do inspections or their annual visits, so to speak. It isn't, you're not required to know the whole book. However, if you're doing everything that you're supposed to be doing appropriately, generally there isn't any issues. And I always say the biggest thing that you can do is document. Everybody has heard the term, if it wasn't documented, it wasn't done. And that is very true. So any care that you provide for your clients, your medications, all of that, you need to make sure that you are documenting that. So what do you need to know to be in charge? And so the facility organization, this is always super important. So things like your mission statement, your org chart, which we talked about, right? Where do you fall? Who do you oversee? Who is your direct supervisor, right? What's that chain of command? Your state statutes. There's also skills checklists. I don't know if anybody knows that, but there's skills checklists for LPNs, LVNs, your nursing assistants, and as well as the RNs. So a lot of times in a lot of facilities, of course, depending on the size of the facility, they'll do like annual skills fairs. And this is for you to, refresh skills, making sure that you're, even for skills that you may not have done in a while. So it's a nice little refresher. Um, and then there's, knowing the job descriptions of the team members. So one, knowing your job description, what you're responsible for, as well as what your CNA's job description is as well. And anyone that could potentially be cross-trained. Like, for example, we have some that are both med aides and CNAs. So if let's say they don't have a shift available to pick up as a med aid, they could pick up a shift as a CNA because they have both certifications. So they still have to work within their scope of practice, right? Depending on what job that they are performing that day. Um, for regulations, inspection protocols, and inspection standards. So again, that book for regulatory compliance is very large. I don't know if anybody's ever, been in a long-term care facility and seen the big red book, but it is pretty big. Administrators, DONs generally will use that book as a reference guide. Um, you'll also need to know your HIPAA, right? What are your HIPAA regulations? I mean, everybody knows what HIPAA is, but being very careful, right? Somebody calls to say, hey, I'm calling to check up on my mom in room 10, making sure that you're going in and you're seeing that, mom, that she's allowed to get information about her mom. Um, CMS regulations, Joint Commission. So Joint Commission. Joint Commission is it's an accreditation body. Um, Not every facility is Joint Commission. All right. So, just as an example, one of the companies that I worked at, I traveled. I was a corporate educator. So, I had seven long-term care facilities. They were all owned by the same company, but the company only chose to have one of the facilities as Joint Commission. When you look at accreditation bodies, they cost money to be accredited. So in order to be accredited, you have to pay, you have to pay to have them come in and do inspections. It's just another gold standard for facilities. But again, not all facilities are Joint Commission. There's another accrediting body that you may see in the hospitals. It is DNV. The first time I heard it, I thought somebody said DMV, and I'm like, why is DMV coming in to evaluate a hospital? But yeah, I just heard it wrong. So like I said, you may have, you may work in a building that's Joint Commission, you may not. The National Patient Safety Standards, your National Patient Safety Goals, you can look online. National patient safety goals are published, and just like the general ones, right? Medication safety is always one, right? The two-person identifiers. But you will see that national patient safety goals, let's see if I can pull it up or not. Um, so if I'm going to stop sharing for a second and I'm going to share my other screen. Here we go. So this is the National Patient Safety Goals. And so you can go, it's Joint Commission is the one that posts these. So each year, they will update their National Patient Safety Goals. And so you can see here, right? You can go to each one of these and you can see the different areas for National Patient Safety Goals. So if I go to Nursing Care Center, I'm going to hit simplified version. Okay. And so it'll list the nursing, it will list, oh my gosh, it'll list the safety goals. So like this one, 2 ways to identify your patients, take extra care with patients and residents who take medicines to thin their blood, record and pass along correct information, about their medications, use hands cleaning guidelines, find out which patients or residents are most likely to fall, bed sore prevention. So these are the 2026 National Patient Safety Goals for long-term care. And so, like I said, you can go to any of these and you can see what the National Patient Safety Goals are for your area of where you're working. Um, Medication safety is always going to be on the top of that, I promise you. Um, and then, of course, other accreditation standards. So Center of Excellence designation is another one. I don't know much about the Center of Excellence designation, but depend, like I said, depending on where you are working, you may have some additional standards. So Center of Excellence is it says a specialized internal team or entity that centralizes expertise, best practices, and resources to drive innovation, improve performance, and provide training in a specific focus area. So, okay. Um, so that's what Center of Excellence is. Um, Other things that you need to know, personnel policies, so the employee manual. Just like as a student, right, at Fortis, you have um, a student handbook, you'll have an employee manual in any organization that you work at. So be familiar with policies, timesheets, how to clock in and out. You may, where's the time clock, how to use the time clock, or how do you record your time? Um, you'll also, you may have to, if a CNA forgot to clock in or clock out, you may have to sign, to make their time clock adjustments, your payroll policies. So, how do request time off? How far in advance do, you have to request your time off in, that kind of thing. Um, your communication and reporting. Um, so, how, if you're going to call in sick, um, how long before, your shift are you supposed to call and let them know that you're not coming? I'm trying to think of what else would fall under there. Um, Yeah. And do they have some sort of, um, what's the word I'm looking for? Way of communication. So a lot of pieces have bulletin boards, where you can find information regarding what's going on at the facility. Others will use, like I had one facility, they used WhatsApp, which I'm not really familiar with WhatsApp, but they used WhatsApp as a way of communicating with nursing staff. So just that kind of thing, making sure that you're, attending meetings and things that you're supposed to be going to, like if they're going to have a skills fair, making sure that you know to be there. Um, I'm trying to think of what else. Meal and coffee breaks. So most places will give you like 2 10-minute breaks throughout the day, plus your 30-minute lunch. Depending on what your role is, maybe your lunch is a little bit longer. Do you have to clock in, clock out for your lunch, that kind of thing. Your smoking policies if you smoke, use of phones, personal cell phones, and other electronic devices. Generally speaking, just like within clinicals, you really shouldn't have your personal cell phone out. Make sure you're not taking, pictures of residents, recording residents. You shouldn't be listening, you shouldn't have your AirPods in. You should, be fully alert to what's going on the unit. And of course, every facility is going to be different, and they may have regulations that how they enforce those are completely up to the facility what uniform regulations are. So some facilities, they color code their scrubs. So you may have to wear specific color scrubs, or you may be able to wear whatever color scrubs you want to. Um, and then the computer systems. So what type of, EMR, system you're using. And then other things like what's the general shift routine for the day? Depending on what shift you're working. Each shift is going to have specific assigned duties that they must do, in addition to, so like I work overnights, so, I get to change all the oxygen tubing, the nebulizer tubing. I print the report sheets for the day shift, right? I get all the appointments, paperwork done in addition to other stuff, but know what each shift is required to do. Um, Reporting methods, your procedure manuals. Procedure manuals, I've worked in some facilities where they don't have a specific procedure manual, but they'll use like the clinical skills. You know how you guys get that clinical skills textbook that gives you like the step-by-step process on how to do your skills. A lot of facilities use those for their nursing skills, so they may have that book on their unit. Uh, nursing care plans, uh, excuse me, guys. Your PICSIS, your cardiac system, what's needed for your care conferences, the transcription system. So with the I can't even say it, the transcription services, most providers do that themselves. They'll either type their notes in or they'll record them, and then a transcription service will put them into the EMR. Um, very rarely, I mean, unless you're, getting um, unless it's after hours and you need to get an order for something, most of the time you aren't going to be, putting a whole lot of orders in, unless, like, unless you're day shift. But, so it just really kind of depends on where you're working. Emergency orders are always different. You're gonna, get those, you may get verbal orders there. And then your clinical references. Also your admission, your transfer, your discharge process. Obviously, you need to know what to do if you have to send somebody to a hospital, if you're discharging them to home, or another facility. This is another one, and I'm going to promise you this is always super important to do is the valuable inventory. So when a patient gets admitted, always make sure that you document on that inventory sheet everything that that patient brought in with them. Dentures, jewelry, hearing aids, glasses, their clothing. You want to document on that inventory sheet, because they may say that they brought something with them that they didn't bring with them, and of course now we can't find it. Or at the same time, they brought something in, we have it documented and we can't find it, right? So we want to know, we want to have accurate information. That becomes part of the patient chart. Hearing aids and dentures are always going to be your biggest issues because what happens? People take their dentures out and they put them on their tray or they put them on their bedside table. They inadvertently get put in the trash or sent back to the kitchen, which ends up always being a mess. I cannot tell you how many times we've had to go through digging, we've had to go digging through the trash in order to find somebody's dentures. It happens more often than you think it does. So always keep track of that. Death procedures, what to do in case somebody passes away. And this is, depending on, where you're working in the situation, we're do, if you're performing CPR, you're going to call 911. But if somebody was expected to pass, what are the procedures for that? Other things, your side rails, your chair bed alarms. So in long-term care, we do not use bed alarms. We don't use side rails. Okay. So those, generally aren't anything that you need to worry about in long-term care. Now they may have like the three-quarter length side rails or the half length side rails that literally are just used at the top of the bed, maybe to help with positioning. But if they can't use them for positioning, then generally speaking, they are not going to have any other side rails. Chair and bed alarms, we don't use anymore. Restraints also are not used in long-term care. It's more of a danger than it is helpful in long-term care. Too many things can go wrong with the use of restraints. Your oxygen protocol, where the oxygen is kept. Um, Always a good idea to know that. Do you have tanks? Do you have, the little machines? Your patient transfer, your back safety, your body mechanics, your door alarms, standard precautions, security, smoking policies, and that's for your residents as well. Some facilities will allow residents to smoke, if they are able to, depending, it really kind of just depends. Um, they were a smoker, then they may be able to go outside and smoke, either unsupervised or supervised. There is usually a screening process that takes place for that as well. Trying to think of what else you might come across. Door alarms. Why are doors alarmed in long-term care? Why do we alarm the doors?
elopement risk.
elopements, and that's primary too. And then, of course, we know with the state of the world nowadays, right, more and more facilities are actually keeping their doors locked, continuously just because, for safety of staff, as safety of residents. So there's a variety, but elopements is a big one. And so, elopements happen. So we keep they may have what's called a wander guard or a wander alert, depends on where you work, where they call them. Um, and it's a little tag that they wear like on their brace, on their arm or their ankle. And so what happens when they go close to a door, the door will lock and the door will alarm, just letting you know that somebody is trying to leave the building. That is not supposed to leave the building. Um, and then, of course, you have to respond to that. And I will tell you that we actually, um, a long time ago, this is forever ago, we had a client who, um, was a wanderer. I want to say you had Parkinson's disease, but don't quote me on that because, like I said, it was a long time ago. And they, he had a wander alert on, um, and somehow managed to get out of the facility. Don't know. The alarms did go off, so that wasn't an issue. Managed to get out of the facility. Nobody even noticed. Um, and so he had managed to get out of the facility, got onto a main road, very busy main road, and got hit by a car, and then ended up passing away from his injuries. And so these wander alerts, if you hear the alarms and, we talk about, you may hear the terms alarm fatigue, right? And things like that, which absolutely is a real thing, because, you hear call bells in your sleep after a while. But always pay attention to those door alarms, because it can be devastating, should somebody get out of the building. They can get hurt. And like I said, even, he got hit by a car and then died from the complications of that. Other equipment, your oxygen, your suction equipment, therapeutic or specialty beds. So we always use low, what are they called? Pressure relieving mattresses, for all of our residents in long-term care. We also have low air loss mattresses. Okay, low air loss mattresses, are for those that either have pressure areas or are at risk of developing pressure areas. So we'll put them on a low air loss mattress. Be careful with using those too. Those are, they can be a little bit tricky, as well. We had a resident with a low air loss mattress. Has anybody seen a low air loss mattress? That's one that has the pump at the bottom and it, as you move, okay. So we had a resident, who was on a low air loss mattress, and the CNA was in there changing the resident, and had to end up, now I don't know why, not, but anyway, as he was putting pads underneath her, the air built up and it literally rolled her out of the bed onto the floor. So always be really careful with those low air loss mattresses. What else? Respiratory equipment. So, your oxygen, your suction equipment, your nebulizers. If you have trachs, where do you find that? And then for food and dietary, how do you order the diet? How do you, request any diet changes? Um, what's the tray service process? Generally speaking, dietary is going to come and bring, the trays to the unit, and the CNAs and the nurses will, go ahead and pass the trays. Some facilities require nurses to help feed in the dining room or even pass trays in the dining room. So know what your processes are is super important there as well, so that you are where you're supposed to be at the correct time. Um, is there any food stock on the unit? Some places have um, snacks and things that are available. What else? Making sure that you know what the diets are, especially for those that are on the special diets, so that you don't give somebody the wrong foods. What are the feeding policies? This is one thing too with feeding policies. Um, let's say you have, two patients in a room. One of them is able to feed herself, the other one is not, and the other requires, to be fed. You cannot, you have to feed them at the both at the same time. So you can't bring the person that has, the ability to feed themselves. You can't bring her tray and not feed the other resident at the same time. So be aware of those things. Um, and then is there a family tray policy? So, if family wants to come in and eat with their loved one and they want to order from the dining room, what is that process? Your nursing care procedures, your assisting your providers. So morning and evening care, what ADLs are done, your bathing, your showering, your bed baths. Most residents get showers 3 times a week, and then they get, their like a bed bath or just washed up on the other days. Oral care. Um, Oral care is a big deal. How many of you are CNAs already? I don't remember. How many of you are CNAs? Um, I am I'm really big on oral care. And so, think about how, you've been sleeping all night and, you have that wonderful morning breath, okay? A little stinky morning breath, right? That we all get. Do you want to eat breakfast if your mouth is all nasty and gross? No, right? So offering oral care to them in the mornings, washing their face, washing their hands, so that, they, encourage that eating. I've just seen some really horrible mouths. Just be really mindful that we should really be providing really good oral care. What else? Um, Bed making, not everywhere is going to change the sheets every day. They may have a specific, what's the word I'm looking for? They may only change the sheets every other day or whatever the policy is. No, you have equipment. I got so used to the facilities that I worked at before I moved to Texas. We had the blood pressure machines, so we had the Dynamaps, and everything available to us. And when I moved to Texas, they don't have those here. Like you don't have the machines to roll around with. So I had to get my own blood pressure cuff, my own pulse ox, and all of that stuff. So know your equipment, know how to use your equipment. Catheterization is another big one. Making sure that you know how to insert your Foleys, even do straight caths for, either urinary retention or to get, what do you call it? Urine samples, enemas, suppositories, make sure you INOs. So recording your INOs is going to be important as well, especially with your Foleys, your specimen collection. A lot of places have outside vendors for labs. They'll come in and draw blood and do things like that, but you may still have to collect the urine and stuff. Where do you store it until they come and pick it up? What procedures would you have to assist your providers with? So this a lot of times is your like if you're with the wound doctors that come in, depending on how often they come in, you may have to follow the wound doctor around while they're doing rounds, colostomy care, glucose monitoring, NGG tubes. Don't see a lot of NG tubes anymore. Not saying that you may never, G tubes are still pretty common. Post-mortem care, and your standard precautions. Um, Post-mortem care, I'm going to go back to this. So post-mortem care, we've talked about, cultural competence and, religion and spirituality and all of that. And so one of the things that I do want to point out with that is with post-mortem care, if, you have a resident that is getting ready to pass, or it, even is in hospice and they're caring for them in your facility, if you think that there is any specific, what's the word I'm looking, any specific spiritual or religious, always ask. So I had a resident, I'm not sure, they were Middle Eastern. I don't think they were Muslim, but I don't remember. And so the mother was getting ready to pass, and the son was her primary caregiver. And so, she was getting, as she was getting ready to leave this world, um, I asked the son, I said, is there anything special that we needed to do once his mom passed so we didn't violate any, specific religious or cultural beliefs? And his was don't shave the body, which I thought was interesting because it's not something that we normally do is shave anybody once they pass away. Although one thing I guess with women, if they have, sometimes older women have the little, like they start to grow a little beard or a little mustache. I thought that maybe that was what he was talking about. And I just made sure to let the CNAs, not to shave her, because normally we'll do, like we will shave for dignity issues, but I just thought that was interesting. So always ask when you're, before you provide postmortem care. And then, of course, your medication equipment, your pharmacy ordering, the unit stock, um, and then, a lot of, depends on where you work, but a lot of places have, um, what do you call it? Like over-the-counter medications are going to be kept separately. They tend to use a lot more over-the-counters. So those are generally ordered by the facility. So things like, your Tylenol, your ibuprofen, your vitamins and things like that. A lot of times those you'll be able to see in a stock room. Any adverse events, what to do if the resident has a change in condition. Narcotic counts are done every shift. So the ongoing and the offgoing nurse are going to both count the narcotics and sign in the book that the count is correct. You also need to know what to do in case the count is off. Um, and then your documentation, with the changes in CMS, everyone's pretty much gone to electronic medical records. However, just like with anything else, you have to be, you kind of have to know what to do in case the power goes out. What are the processes, if the power goes out, then you may have to document on paper. Most places have a backup system where you can print the MARs and the TARs, and be able to paper chart for that shift or until the power comes back on. Are there any special forms like if somebody falls and you have to do neuro checks, then there may be a special form that you have to use. What are the fax and email standards and incident reports? And then of course your list for wanderers and things like that. Um, let's see. All right. So lots of different things that you'll have to do as a charge nurse, and it sounds like there's a lot. But once you're in a facility and you start working in the facility, you'll understand all the processes. So it's not as overwhelming generally as it looks. Um, Collecting data. Um, so the normal data, your weight, your temperature, and the rest of your vital signs, and really doing that really good head to toe assessment. And if you're working on a unit and you're full time, you're going to get to know these residents. So the best thing that I can tell you is when they first come in is make sure you do that really, really good, thorough head to toe assessment. Look at every inch of their body, and document anything abnormal that you find, whether it's a bruise, whether it's a red mark, whatever it is, you want to document because the more thorough that you do that first initial head to toe assessment, then you're going to be able to recognize any changes from baseline after that. Um, we want to try to keep the routine as similar as possible to their home life, right? Because that helps to limit confusion, delirium, all sorts of things. You also want to know how they communicate. Communication is a big thing. One of my, down here, a lot of my residents are Spanish speaking, hence the last name. I do not speak Spanish. Okay. So that has been a barrier sometimes, but there are translator services that are available. I had a patient before I left Virginia. He was deaf and mute. But I guess the biggest barrier for that was when he came into the facility, nobody told us that he was deaf and mute. We didn't find out until he got there, which turned into more of a very serious situation because we could not communicate. But we did find an American, he used American Sign Language. And so we were able to, there's an app, and I don't remember what the name of the app is. But there is an app that they can connect with on the iPad, and he can sign and she can tell us what he needs. And so that was that was how we communicated with him. And it worked out really well once we got it up and running. So um, just knowing what your resources are for communication, of course, any cultural and religious, anything like that, you want to get that immediately. Um, Employee home problems. So this is always a big one. Um, and so those of you that are CNAs, um, are you planning on staying at the same place that you are at once you start nursing? So I got one
I
yes.
think I want to go to somewhere else.
You want to go to Janae, you want to go somewhere else. All right. So one of the biggest or the most difficult things, especially staying at the same facility that you're at, not saying that it's impossible because I've seen some do really well. Sometimes that role difference, right, can be an issue, right? You were a CNA, they're your peers, and now you're a nurse, right? And you have responsibility over them. And so sometimes that can be cause of strife. But you want to be careful when you're working with them. Everybody has issues outside of work, right? Everybody has issues, no matter, I mean, doesn't matter who you are. Um, right? Everybody has a life outside of their job, outside of school. And so you want to be really careful. You want to be able to counsel, provide guidance as much as possible. But you also have to make sure that you aren't letting anybody, walk all over you or using that as an excuse in order to not get their jobs done. And so in some cases, you may have to escalate it. to somebody above you, especially if we're, trying to work with people that we've worked with at one, on one level, and now we're trying to work with them on a different level. Um, So working with, even, with CNAs or even some newer nurses, maybe the new nurse, and then, at some point there's going to be a newer nurse than you. Um, One of the best ways that we can, help is to show somebody how to do something or to teach somebody. So I always use the show one, do one, teach one method. And so what that is, let's say, think about like when you're in the skills lab, right? Um, your instructor either plays a video or demonstrates a procedure for you, right? And then you go back and it's your turn, right? You get to do the procedure. And then the last part of that is once they've done the procedure and they have, demonstrated that they can do the procedure effectively, then they teach somebody else how to do it. So the show one, do one, teach one is a really good method for teaching, either another nurse or a CNA. Always provide praise and reinforcement. If they don't get it right the first time, go through it with them again, and help them. Does anybody need a break? Yes. Okay. So let's just take a quick one. Be back at 5:10. All right. So let's talk the next couple slides. I'm going to stop sharing. The next couple slides, well, no, I'll share, but is talking about the families. And so a common problem in a nursing home is, dealing with complaints of family members regarding the care of their relatives, okay? A lot of times, it's or a common complaint is, right, that they're losing that there is not losing, there involves physical care. Um, and they can become verbally aggressive, they become angry, they are often very critical. And we have to look at it through the family and through their eyes, okay? And so their loved one is aging, they're losing their abilities, they're decompensating, and it is a time of loss for the family. They may feel guilty about placing them in a long-term care facility or, not being able to be their primary caregiver. They also may have grieving issues that they have to deal with. And so lashing out sometimes is, their way of, relief, I guess. And so they also may project blame onto nursing assistants or even, nurses themselves. And so there's, a variety of things. And nobody wants to be in a long-term care facility. Okay. It's not a goal in life, right? To grow up and get old and to be in a long-term care facility. Um, you know, and like I said, a lot of families may feel guilty because they can't care for their loved ones at home, and they want everything to be perfect, and it's not, we can try to make it as perfect as possible, right, but it's never going to be perfect, and in some cases, that family is just never really going to be 100% satisfied, but we need to try to do our best to provide their care. So when we're working with, a family that is complaining or, even very demanding, um, first thing that you want to do is, we talk about building a therapeutic relationship with the clients or the patients. We also need to build that relationship with the family as well. So you want to try to build a relationship with the family. You also want to encourage them and allow them to express their feelings. Um, and apologize if a mistake has been made. And so I know that's hard, busy, lots of stuff going on. But if a mistake has been made, if something has been overlooked, apologize. You know, don't want to say, oh, we're short-staffed today, right? No, we want to just apologize and try to fix the situation as best as we can. Be specific regarding steps to remedy any adverse situation. You want to see if you can even try to identify like what the underlying issue is, right? Like I said, they may feel guilty because, they're not able to care for their loved one at home, whatever the reason is. Um, Spend time with the family when the demands or complaints are not being made. So, like, even when everything is good, make sure that you're spending time with the family if they're there, right? Again, that's going to help you build that relationship with them. Um, Develop a rapport. Like I said, can't tell you how important that is. Always be open and honest. So, explain the condition, their disease, and the expected behavior. I will tell you, dementia and Alzheimer's is probably one of the hardest ones, especially when the family, um, because they don't recognize their family anymore. They may not recognize their family anymore. And the family is grieving that because the family, they want them to remember them. They want to remember, their lives and everything like that. But it's generally not what happens. To be fair and to be honest, the person with dementia or Alzheimer's, unless there is another underlying disease process, which in a lot of times there are, but most of the time they're not in pain, they're not uncomfortable. Okay, they're in their world, okay, and so we have to meet them where they are. Um, and so trying to explain that sometimes to family members, it can be very difficult. Alzheimer's is harder on the family than it is on the clients. Um, and so you can even suggest to them to join support groups like Alzheimer's support groups and things like that. They, will help. And not only does it help to explain the disease process, but they can, share feelings and frustrations. They can hear other stories about other families that are dealing with similar situations. And you always want the families to be involved with the residents, right? You want them to keep coming and visiting because we know that that's good for them, that it's good for the residents, it's good for the families. So you want to encourage that. Um, and you always just want to, you want to, we strive always to provide the best care, right? I mean, that's the goal. We want to provide the best care to the clients. And it does seem that sometimes the families wants and needs can be overbearing and um, sometimes even unrealistic. But we want to still try to do the best that we can to make everybody happy. Um, and it can be it can be difficult. I don't know if anybody has ever had to deal with difficult families, even difficult patients in the past. And sometimes it seems no matter how great a care you're providing to the client, sometimes it just seems like the family is not ever going to be satisfied. And in some cases, they may not. Um, you just want to make sure that you go in and that you're doing the best that you can when you're providing care for that client. And I know you guys have heard this before, and I'll say it. Every person in a long-term care facility, every person in a hospital setting is somebody's mother, father, sister, brother, uncle, aunts, grandma, grandpa, niece, right? They all have families, whether their family is active or inactive in their lives. All right. They are all people. All right. And they deserve respect and they deserve to be, provided with the best care that we can provide them. Um, and so even that resident that I prefer, I don't know why. I love the crotchety mean ones. Like I always, they're the grumpier they are, the more I'm gonna try to win them over. I don't know why. That's just the way I am. I don't know if it's because I'm from New York and I just think that's just normal for me. Um, but think about that. They're human, right? And they all deserve to be treated with respect. And we try to provide that for as much as possible. And so when you're in there and you're caring for them, they're humans. They, whether, you know, you whether they're nice to you or they're mean to you, they are all human and they deserve our care and they deserve our respect. And they're there because they can't care for themselves or they don't have somebody that can care for them. Um, if you ever find yourself getting frustrated with a client, please walk away. Please walk away. You don't want to say or do something that could potentially get you or put you in a position to get you in trouble. Um, and trust me, I've had my share. And I'll share a story. Um, we had a resident get admitted. And when I first came on the shift, and I don't know if I told you guys this story or not, when I first came on shift, she was laying in bed, her family and her grandkids were in the room. She was like half asleep, seemed like the sweetest lady in the whole world. I went in and I got her vital signs. I asked her if she needed anything, and she said no, she was good. I was like, great. And I'm like, okay. So family stayed for a while, probably around midnight, 1 o'clock in the morning. They had already left. Um, And I hear I'm across the hall in another room because the call bell had gone off, and I'm like, I didn't know where my CNAs were, but I was like, I always answer my call bells because usually it's for pain medicine. But so I'm in the other room across the hall, and I hear my CNA yelling for me, and I'm like, oh my gosh, what's going on? So I go across the hall into this new admissions room, and here this lady has my CNA pinned in the shower with her walker. So she needed to use the restroom. So the CNA had gone in to assist her to the toilet, um, and got irritated, or I don't know. Nobody knows what happened. Even the CNA is like, I don't know what happened. She was on the toilet. And then the next thing you know, she went to go help her off the toilet to get her to go back, to put her back to bed. And she like, something happened. And so she had her walker and she had my CNA pinned in the shower in her bathroom. And so she's calling for me, and I go in there. I was like, oh my gosh, I'm like, what's going on? And she was like, get her out of here. And I said, yes, ma'am. I said, I absolutely will. I said, but you need to put the walker down because she can't get past you because you have her, like, she had the walker up and she was like poking her and trying to push her into the shower. And I said, well, we need to put the walker on the floor. And I said, why don't you come out of the bathroom with me? And then this way she can leave. And she said, no, she just needs to get out of here. And I was like, I don't know what to do because you're not moving. Like, and she's got her pinned in the shower. So finally, about 20 minutes later, me and the other nurse, we finally were able to get my poor CNA out of the bathroom, out of the shower. And this lady would not let any of us near her. She started barricading and moving the furniture in her room so that her bed and her bedside table, we didn't have access to her. She had it all arranged so that we couldn't get to the other side where she was. And she started pulling stuff like she was getting ready to throw the lamp at me. Fortunately, I was able to jump over the bed to grab the lamp to get the lamp out of the room. I had to pull the call bell light or the call bell out of the wall because she was trying to wrap it around her neck. I even couldn't even get a chance to call 911 because I couldn't get out of the room. So I called, I made a couple calls and they're like, well, just let her calm down. I'm like, oh my gosh, are you serious? She calmed down and then she started walking in the hallways. Well, she had her gown on with the back wide open and she didn't have anything underneath her gown. So her rear was just exposed for everybody. And I was like, ma'am, I'm like, look, we have males in this facility. I need you to cover up. Can I get you another gown or something to put on? She wouldn't let me near her. So about 45 minutes later, I was able to finally get another gown on her. Long story short, I don't know how, but we ended up getting her back in bed. I went home. The next day I found out that they CNAs had gone in, they needed to get her weight. And on the way, walking to the scale, something happened, and our staffing coordinator got it. She was just walking out of her office, and the lady swung her walker at her, and the administrator had to come. They had her down the hallway. They had her like at the end of the hallway. She was trying to attack the administrator with her walker, so they ended up having to call 911. The police department came. The police officer wouldn't do anything because she had a diagnosis of dementia until she attacked him with her walker. And then he had to handcuff her. And then he handcuffed her. And then apparently, even handcuffed, she was kicking. So he had ended up having to shackle her, but they still wouldn't take her. So they had to call 911 again to get an ambulance, and then take her out of the facility. Um, Come to find out, I don't know, sometimes when you have people that are not nurses doing the admissions, you don't always read all the little lines on the paper. She was supposed to be discharged to an inpatient psych facility, not a skilled care facility. Okay. She was supposed to go to inpatient psych. How she ended up in our facility, I do not know. How I managed to keep her safe all night with limited resources, I still will never know. Um, Yeah, I'm just glad that she didn't get like super violent until the day shift, like because a lot of times people don't always listen to night shifters about what residents do at night. They're like, they're so sweet during the day. I'm like, oh, then come work nights and see how some of these are, especially when they start sundowning and things in the evening time. It's a whole different personality that we end up seeing. Um, so yeah, so bless her heart. I don't know what happened to her. I know when I came on shift that night, the next night they were like, um, I forget, they called me for something. Um, and I was like, so what do I do if they try to send her back? And they're like, you don't accept her. And I've had situations like that before where they won't call, they'll just show up at the facility. And I said, what happens if they just show up and they don't tell me they're coming? She goes, you don't let them in the building. Absolutely not. So, but yeah, so that was a totally, there was nothing I tried everything, even leaving her alone and like letting her wander and stuff. That turned out to be a little bit better, than trying to confront, like not confront her, but to try to interact with her. So I literally just followed her around the unit for a little while and just making sure that she didn't get hurt or hurt anybody else. Because the last thing anybody else wants is, some stranger walking in another room in the middle of the night. It's bad enough nurses have to wake them up, let alone having another person wander in. But yeah, so so I've had some interesting experiences like that. I just thought was like, wow, I couldn't believe it when I saw that on her discharge. She was supposed to go to inpatient psych, but she ended up with us. All right. Any questions? All right. So that is it for today. I hope you guys have a great week. I have a meeting in a few minutes. I will get your grades posted shortly. All right. Y'all have a good one.